So look, thanks so much for the invite to talk. And as you rightly said, I've been working with Graham Ellis for a while now, actually, since we met at the World Hospital at Home Congress. We also met with David and realised that there was a much wider global community innovating in acute hospital at home. And with Graham, we co-founded, and with some other colleagues as well, the UK Hospital at Home Society, and there's our logo at the bottom right there. But for my day job, I spend half the week leading an acute hospital at home team in Oxford, the John Radcliffe Hospital, and the other half of the week I'm an academic, much like David, and my chair is in acute ambulatory medicine in the medical school at the University of Warwick. And one of my main interests is around how we use diagnostics, and so my research NIHR funding is up there, as well as the research collaborations in the West Midlands, and also something called a MIC, which is about diagnostics research. So we're at a DigiFesr, and I wanted to look at what the art of the possible is, and how does digital enable us to really innovate in the acute hospital at home. So just a couple of background slides, because we had a fantastic scene setting already. And what we've seen in acute medical admissions over time, this is of data from NHS Digital over the last 10 years, is there's been an inexorable rise in acute admissions. So even without hospital at home, the status quo of having a fixed hospital bed base is not going to meet the need in the future. So we're talking about hospital at home now, and I'm thinking, how do we future-proof the acute medical care pathway? Our overall bed days, which is the orange graph in the middle, the total available beds in hospital has actually been reducing. And whatever our politicians say, the total number of beds in which we could put our increasing number of patients in is getting slower and smaller. And so that leads to the bottom line, the graph down the red, which is the proportion of beds that are occupied, or bed occupancy. And that has been increasing. The average of bed occupancy has been increasing each quarter by quarter by quarter. And it's said that over 80 to 85% bed occupancy, the hospital is in a harm state. There's increased readmissions, there's increased mortality, and increased nosocomial infections as well. So a stressed hospital does not offer the best care for patients. And I believe the hospital at home has a significant contribution to make for a future-proof acute care pathway as the absolute need increases over time. So what are our core principles? We are providing a credible alternative. I don't want to do everything the hospital does, but I want to do everything that the patient needs right there and then in the home. So it's got to be credible. It's not replacing literally everything. That means we get to think about what the acute hospital does and say, do we do that because it's just culturally what we always do? What can we do that's different, that's tailored to patient need? As the majority of the patients we see are old and live with frailty, that multidisciplinary assessment is critical across the allied health professions, as well as being physicianally led. We need to make diagnoses. One of my big issues that I've been trying to push forward in the UK Hospital Home Society is for us to be credible and want to replace admission completely so the patient doesn't need to go. We've got to bring that diagnostic package out of the ED into the patient's home. And yes, we've got to give treatment, and we've got to give support and care monitoring. And hopefully I'll explain how our digital platforms can help us do that. But that's the kind of package. We've got to just try and take out everything that we do that's right for that patient in terms of understanding what's wrong, treating them, and seeing if our treatment works. So we need to effectively get under the bonnet of what people are doing in hospital at home. What are the processes of care? What kit you take with you? What can you actually do in the home? And whenever we do any surveys in the UK, no one will be surprised about this. There's large variation in what can be delivered in the home and care home through our current hospital at home services. Some work I did with Graham. I'm looking at a UK national survey that I lead called SAMBA, Society of Acute Medicine Benchmarking Audit. We just asked around and said, for every UK hospital, who has access to hospital at home? Actually, only half really have access to hospital at home teams. It's not really a national strategy yet, but it should be. And then we said, well, how many can do diagnostics in the home as well as everything else? And so what we've got here on the left, there's a graph there that says what all the sample processes of care, so intravenous fluids, for patients dehydrated, and the converse, intravenous diuretics for patients who are overloaded. Can we do blood tests in the home? Can we give oxygen? And can we give IV antibiotics? And basically the bar above each of those combinations is how many hospital at home teams can deliver certain combinations. What you find is that very few can deliver all of those combinations, only one, I think. People can do one or two or three of the other in a kind of a picking list, but hardly anyone can do all of those ranges. And that's not all the things that we need to do to deliver hospital at home. So what does that tell us? Well, there's a big opportunity to develop diagnostic and treatment platforms. And I believe that digital approaches can give us confidence and help us around some issues around governance and oversight and developing access to the right kind of physician. So a little bit about point of care tests, so for blood. So what really helps us is the kind of handheld, anytime, anywhere approach to diagnostics. So in the interest of balance, obviously, a range of providers do point of care tests. So there's a few mentioned there. Abbott, we use the Alinity system, but Siemens made the Epoch, and Rush also. But we tend to use the iStat Alinity. And it's essentially, it's handheld. There's two versions there. There's a left, which is touchscreen for people that grew up in the 90s. And on the right, there's buttons for people that grew up before that. And we essentially choose which cartridge you want to use, have a range of analytes on the cartridge, and it's whatever our common encountered problems. We see a lot of patients with acute kidney injury, electrolyte disturbance, heart failure, and also we need to monitor a lot of patients who are on IV fluid therapy. So for us, we choose a range of those cartridges to take with us, and we see a lot of patients who may or may not be septic. I want to make sure that the patient's in the right place, so having their lactate and gases as well. And we give oxygen at home, so knowing what the carbon dioxide is doing as well is really helpful for us. So we choose our system based on what the kind of common conditions are, our common clinical questions we're asking. And also, these are networked into our laboratory information management system. And that's, again, huge evidence or advantage rather of our digital platform. I can do a set of blood tests in the patient's home, and it will appear in the hospital's electronic health record. We'll talk a little bit about that shortly. So again, ensure that wherever the patient is cared for in our system, any other clinician who wants to look at the notes and the records can see what's been going on. And David brought up imaging, which I think is really important. We traditionally think that patients need to go somewhere to get imaging, and imaging is an important part of our extension of the physical exam, as trying to understand what's causing the change in the physical signs that we're picking up when we examine the patients. And that's where I think there's a huge role for handheld portable ultrasound. And again, in the interest of balance, a number of companies make handhelds: Butterfly, Vscan, Philips, Claris, to name a few. In our healthcare system, we use the Butterfly IQ in Oxford, in our hospital at home, and that's partly around the ease of image sharing, which I'll come on to shortly. And again, it's thinking about what are our common encountered clinical problems. Very often I'm asking a question about what's the fluid status of this patient. Are they really clinically dry? And can I see that on the change in the physiology ultrasound, or is there fluid everywhere? And this is a patient that needs diuretics. And then I can say, well, are my diuretics working? Is the fluid around that chest getting better? Let's have a look with the ultrasound. So it allows us to make diagnosis and also to follow patients to ensure we're giving the right therapy. And the importance of our image sharing is it helps us train more clinicians in ultrasound and with mentorship. And also it means that we can evidence our governance so that we're making the right decisions based on our images. And in a cloud-based system, we can share easily, and also we can put links to those cloud images in our electronic hospital record. And so anyone can then go back and look at the images I've taken and look at my narrative about why I did what I did with this particular patient. So what's our operating model? So this is actually what we do in Oxford, but we wrote about it quite recently in that open access paper there. And so everything starts in the acute hospital, reaching out into the community. We have a mobile team, which will be a range of clinicians, as David mentioned as well in his talk. And we'll be thinking of how we use our diagnostics, and we can deliver intravenous treatment and oxygen if needed. We'll be going to the patient's home or increasingly the care home. And then in terms of real-time uploads to our hospital electronic health record, with the vital signs, clinical progress, the blood results, and the links to the imaging. And because everything's in one place, it really helps our multidisciplinary team discussions. So we can target whether we need an allied health professional to go to the patient's home. We can involve specialists to support the generalist physician care that I deliver, so that if a patient can stay in their home or care home, but still get access to an organ-specific specialist like a cardiologist or a chest physician, for example, and they can look at our images and give opinions and say what they think needs to happen. So that's an important part, I think, of how we deliver care. I want to give an example case that might put all this together for us. So how can our digital tech support hospital home diagnostics and deliver hospital level care in the home in a way that ensures the patient gets the right care? So I'm going to tell you about a patient that I'm seeing at the moment, actually, a lady in her late 80s. She lives at home. She lives alone at home, but supported by her family and her carers, and she's a very independent soul. She had a previous stroke, which is a big challenge for her because she has a left arm and leg are very weak, but nevertheless, she can walk with some assistance. However, she's lost her ability to mobilise over a number of weeks. It's been slow and gradual, and she's doing much less able to engage with her carers and mobilising. So she's pretty much bedbound at the moment, which is not right for her, and she knows something's wrong. She's also breathless. And she had a CT scan done recently. She'd had some blood in her urine, and they were concerned, and so they did a fairly wide-looking scan in her renal tract that caught a bit of the bottom of the heart, and they saw there's a small pericardial effusion there. And when she became, when the GP realised she was breathless, they were worried about what the fluid around the heart was doing. I'm not sure. I'm sure there's some non-medics on this call. So when fluid collects around the heart, it can compress it and stop it from beating quickly and filling properly, and that will cause an issue in terms of getting the blood around the body, and patients can be quite unwell with that. And so her family physician said, well, I need to get to hospital right now because you're breathless and there may be this pericardial effusion causing a problem now. So she did go, but she declined admission. So she went to the hospital, but didn't want to stay. Didn't get time for diagnostics and said, I'm just going home again. And at that point, we were involved. So although she'd been to hospital, she didn't actually get any of the sort of any of those benefits of differentiating quite what was wrong. So when I saw her at home, she was sitting up in bed. She did look breathless, but her oxygen saturations were normal and her blood pressure was actually okay. And these are images that I took on her bed, which was downstairs in her sitting room. I'm just going to play this now so you can see. So I've got the probe looking into the right side of her chest. And on the right-hand side, this blob here, if you can see the hand pointer, this is her liver. That's her diaphragm. And just hiding under the liver is her kidney. But we've got this all dark area here that we don't normally see. And when you breathe, your liver moves up and down, as you can see here. This is her breathing. As I say, her breathing rate's pretty quick. And this is all pleural effusion. There's fluid in here. And it's the same on the left side of her chest as well. And you've got a little bit of collapsed lung there and fluid. So there's pleural effusions there on both sides. And then we worry about what's the heart function doing. So this is me, again, moving the probe to look at the front of the chest. And I'm going to play this shortly, but here, this area here is the left atrium. That's where the blood goes in the left side of the heart, coming back from the lungs. And it goes into here, the left ventricle, and it pushes it out through the aortic valve. And this is her right ventricle here. And I'm playing it now, so you can see this is a mitral valve opening, an aortic valve opening. Just to sort of guide you on this left ventricle isn't working very well. We see a bit of the pericardial effusion here. There's a coronary artery moving down here. And this is a pretty big right side to the ventricle too. So I thought, looking at this, but although I do what's called point of care echo, I'm not a cardiologist, so need to find a way to ensure how can we get the precisely right diagnosis for this lady. But there's still this issue about her pericardial effusion. So I then moved the probe to more the side of the left chest. And this is a more kind of common view you might think of having a look at a heart from sort of textbooks. So we have the left side of the heart and the right side of the heart. And this, again, the left side, you can appreciate this isn't really squeezing much of the left ventricle. So that I think there's definitely reduced ejection fraction there. So heart failure caused by reduced ejection fraction. And the pericardial effusion is here, but this is the right side. And when we worry about pericardial effusion, it's the right side of the heart that shows the strain, really, what's called tamponade. And that if the right side isn't happy, then the atrium will collapse because there's more pressure outside the heart than inside, and the same actually for the right ventricle too. And that will stop the heart's ability to pump blood around the body because it just can't get the blood into the right-hand side. But as you can see here, this right-hand side is filling up very nicely. In fact, it's bulging over into the left there, telling us that we've got slightly higher pressures on the right. From the heart failure. So although there was a concern of the pericardial effusion and she's breathless, then doing this in the home helped us go, actually, we don't need to get her in urgently for something called a pericardiocentesis, which is where they take that fluid off. So in real time, I got these images reviewed through our secure cloud by a consultant cardiologist who was very happy to help us. And they said, yes, I can say that's reduced ejection fraction. So in her notes, we can say has had a cardiologist reviewed her echo and go, that's definite reduced ejection fraction. It's not a generalist like me doing it. It's the real deal. It's the cardiologist. And so, yes, I agree. No evidence of tamponade. We can stand down the original concern around the fact that we might need to get her in to drain some fluid around the heart. Actually, it's all okay. So based on that, we could then start a range of prognostic medicines for heart failure, and there's great evidence base. Now, heart failure care has really transformed with recent trials. There's a range of medications we can now give that actually do reduce longevity and reduce hospital admissions too. So increase longevity, reduce admissions too. But because we had the excess fluid around, we gave her diuretics as well, which you hadn't been on before. So using our digital platform, we managed to basically beam in specialist expertise into the patient's room where they are at home, but using our diagnostics and our overall treatment function. So as generalists, we're very comfortable with treating heart failure. We see a lot of it. But when you've got a brand new case, you think, oh, yeah, actually, a cardiologist probably should be involved. This has allowed us to have that cardiologist involvement. Our network diagnostics allow us, I think, to, with a very sort of governance and safety profile, to have a whole range of treatments, as Dave was talking about. We give a lot of intravenous furosemide at high doses, but because we've got point of care bloods, we can see the impact we're having on the function of the kidneys. But with all ultrasound, we can also see, are we getting the fluid off as well? Give a lot of IV antibiotics, and we're going to be moving towards using longer lasting, bigger lines that go into the arm, so we can give infusions, which allow us to have better antimicrobial stewardship and choose the right antibiotic. We get a lot of our intravenous fluid. We're now moving to slow infusions, so we can treat people who have very high sodiums, and so we can bring it down slowly again, avoiding the need to come to hospital. We give iron for anemia. We can treat the hypercalcemia that can sometimes happen to patients with cancer in the home. And we have our COVID bundle, and Dave was talking about a lot of COVID care in the home. We do see patients with COVID, and in fact, we were the first unit to give tocilizumab, which is a monoclonal antibody to improve outcomes in patients with COVID in the home, to a man who wanted acute care but did not want to come into hospital. And he did very well, actually. He needed oxygen, steroids, and this antibody, and some blood thinners. And we're also going to start giving blood transfusions in the home too, as the haematologists are supporting us to that. And although we don't formally do end-of-life care, because our wonderful palliative medicine colleagues are very good at that, occasionally we see patients where there's a concern about is there a reversible problem, but actually sometimes when patients are indeed at the end of life, we do try, or it's not apparent that they're there right now at the end of life, and we do try a curative intent first, but actually it can become pretty obvious fairly soon that this patient is moving towards end of life. So we switch from a curative intent to a palliative intent, and we've done that quite a few times now. And patients and families really appreciate the fact they haven't had to come into hospital, they can still be with their loved ones, and that we've done everything that could be done to look for a reversible cause for someone's decline. We've given some treatment in the home, and we've been able to support a transition to end-of-life care and support families. And they really appreciate that right now, because they've been able to maintain visiting, which is pretty tough in acute hospitals at the moment. So although we don't do formally end-of-life care, we are very happy to support it for our patients who initially before actually there could be an option to reverse an acute medical problem. And so we'll do that in a way that fits families and patients in a much more better and, I think, humane way. So just to wrap up, I think digital platforms will allow us this sort of connected diagnostics and specialist support, so we can broaden what we do for acute medical care in community settings and really help us reduce the need to get to hospital for those initial diagnostics. We do everything and replace that need for admission, but with that connectivity, we can say that doesn't deny patients the right specialist opinion. Hopefully I'll persuade you the importance of our point of care diagnostic tests, both blood and imaging, and how those can be used as in that example in delivering acute medical care. But obviously it's pragmatic focus testing. I'm not replacing the hospital. I'm just taking the bits of it I think are needed for certain patients. But it helps us make rapid decisions in the home. And that, I think, helps the efficiency of the care profile and makes it much more credible for patients and families. We're not replacing the hospital. We're just delivering what's needed for patients who wish to remain at home in their care homes. So I'll stop there. And yeah, please get in touch as well to discuss. My Twitter handle's there and email there too. And please think about joining the UK Hospital at Home Society. We offer very reasonable rates, and it's a broad, bigger community that we need to support and grow. So we look forward to seeing you at future meetings. And thank you very much indeed for inviting me to talk at this one.